Hi, welcome back. I'm still Ellis Sandset, the stroke neurologist from Oslo, and we will now spend some time discussing the results we just heard in the large clinical trials session. With me now, I still have Robin Lemons, but we are also joined by Ellis, Claus, and Carlos from the Netherlands, Denmark, and Barcelona. So let's start. Robin, I mean, you chaired the session. Are you happy?
I'm very happy. Well, I think what strikes me all the time when they present these results for the large clinical trials, how much work this must have been for most of these PIs and sub-investigators and the whole team involved. Several trials were presented that were initiated many years ago with a lot of hurdles, barriers to complete, and then in the end they come and show these results. And I think it's just amazing that so many of them have the courage and the persistence to complete the trials. This is actually separate from the results that were presented, but just to finalize these things over such a long period is just amazing, I think.
I think to summarize that in an 8-minute presentation, it's 10 years worth of work that you put into 8 minutes of where you present your results. So it's a big achievement for all the people who presented today. So, but Carlos, what were the highlights?
Well, it's really amazing. This first day of the large clinical trial session show us how we succeed to put all the spectrum of the stroke research in one session. So from the primary prevention with the polypill trial, also with the pre-hospital with the tactic trial, acute management with TASTE trial, and also the CHARM and the ActiSafe trial, the secondary stroke prevention convinced result, the ICH switch, and also the results of the clinical impact of hematoma expansion and thrombotic events in the Annexa I trial, and also rehabilitation. So the full spectrum is there. So the main highlight is that we are more and more in primary prevention. So stroke neurologists will take over this part of prevention, focus on stroke. It's a strategic position, I think, that we have here. And they succeed in Brazil to run this polypid trial. It's a pilot trial, it's a small trial, but they approach the primary prevention as the primary physicians, and also primary physicians to prevent the stroke using the riskometer, which is a very advanced way to monitor and control risk factors, and they reduce the number of the control of risk factors in this population. I think it's a good achievement. Tactics was really nice. I really love this proposal at a regional level. So how they improve the drip and ship process, and also the number of thrombectomies and reperfusion by 44%, and the door in, door out, which is the time method that is more difficult to improve.
I was also very much impressed by the virtual reality glasses they used for the training. It's such a nice
this is a matter of training and
method.
Also get engaged all these small hospitals, these spoke hospitals in this network, and the result is that for one side, the door in, door out was improved, the door to needle time was improved, but the door to growing time was longer, which is something we need to check what is the problem here. So if you reduce the door in, door out, it's expected that the door to growing is going to be shorter. So because of the pre-notification of the hub. Yeah, what do you think about it?
Yeah, that was also a bit surprising, but this is actually my favorite part of the conference. You know, it's beginning, all the big trials being presented, and we now have time to discuss them. And I guess for me it was also CHARM, which was a very big effort, as you say. It's a lot of people have been working on this since 2018. And initially it looked like the drug worked on edema evolvement, and then sadly after conducting the trial it was neutral. But I think it's very important that we see these trials, we follow them through, and it's amazing work from the primary investigators. And I also enjoyed the switch. Actually, now we see more things being evidence-based on the hepatoma side, we saw in Rich last time, and now we see Switch.
Yeah.
And maybe there's not a big benefit of hemicraniectomy, but at least now we know. Now we can approach the patients and families and lay out the data.
Yeah, and tell us also how important it is to select properly the endpoint for clinical trials. This shift analysis was positive. The shift analysis was the secondary endpoint, but they missed the primary endpoint roughly, because it's the ranking 0.4, I think. But they didn't find any benefit. How do you think it will impact guidelines in a way that this is not a clear positive trial, of course. Yeah. It's a neutral. They missed the primary endpoint, but I think the results are impactful, and it's unlikely to have a trial like this in the future.
Yeah, I think so too. That's of course a difference. I think with the ischemic stroke trials, I've also looked at the benefit of hemicraniectomy, but there were several trials going on at the same time. They pre-specified the meta-analysis, combining the data, and then they had the sample size to show this. So this is just one trial, but it's being done. I mean, it's been recruiting for over 10 years. So as you say, it's not likely that this endeavor will ever be done again. And so, of course, and he showed the meta-analysis, but of course the endpoints for the different trials were different, and the interventions were difficult. So that will not be in the meta-analysis to convince a guideline working group, I think. Depends a little bit of if a guideline working group would come up with the meta-analysis just focusing on this intervention, maybe there's something there. So what the guidelines will do, I don't know, but I think it helps to inform us in clinical practice. I think it will help us inform patients, as you mentioned, and relatives that, well, there is this potential option, and we can then state that it increases their risk. Or decreases their risk, to be in a very independent and non-preferable status like modified ranking 5 or 6. And that this is something that can be considered. I think then in communication with relatives, mainly I would think, sometimes patients, but mainly relatives, explaining that and then getting hopefully a little bit of information how the patient would potentially look at that particular situation can assist us in making an optimal decision. It's not always, I think, that if there's overwhelming statistical significance that we can only conclude to do something. I think a lot of is being done in clinical practice without any evidence. At least there's evidence to support a good conversation, I think, with relatives, and that's important as well.
Yeah. I think with the tactics and the polypill trial, there are also very good examples of having trials where you do research and implementation at the same time, which is in a way undervalued, or we do it too little.
It's exactly what we need. We have a lot of evidence out there, but we fail in implementing these strategies in real world.
Yeah, and also extrapolate our knowledge to more rural areas and try to improve stroke care over there, not only in Europe. I think that's very important.
But I like your point about how the session highlights different areas of research, prevention, acute care, hemorrhage, and also implementation. As you say, we have good treatments, and now we need to implement it also in places that are not close to a university hospital. One of my big take-homes was Peter Kelly's presentation of the colchicine drug, and of course convinced trial. And of course, neuroprotection, anti-inflammatory drugs have, long been evolving, and we have big hopes. And often trials are neutral or almost positive. So I'm curious, what do you think about the trial? Certainly there's room for maybe focusing on a large vessel disease, as he said in the end.
Yeah, I think it's a large trial. More than 3,000 patients were randomized so far, well conducted, multi-center, global trial. I think it's patient selection again. So it's not just take out those patients with atrial fibrillation or cardiovascular strokes, means non-cardiovascular strokes, but also the behavioral lacunas is different. So I think we need to implement bundle care into clinical trials, just not focus on anti-inflammatory effects. Maybe some balance in terms of the antiplatelet regimen, dual antiplatelet therapy or monotherapy, and also the level of control of blood pressure can be unbalanced, and all these issues, and also the structural type plays a role. in the recurrence rate and also the impact. But they include not only the recurrent stroke, but also myocardial infarction. So I don't know if you take it off from the equation. So myocardial infarction, sometimes myocardial infarction, especially in TA minor strokes, create more noise than adding value to the primary endpoint. So we need to check that for the future. But it's an enormous effort to have a trial like this, running by neurologists with a long-term follow-up, more than 3 years, I think 3 years follow-up. It's amazing, 34 months follow-up.
Yeah, median. So many patients were in the trial for a very long period, which also makes it challenging to, and that I think the longer a secondary prevention trial takes, of course, it becomes challenging as it relates to adherence to the treatment, follow-up of the outcomes. We need that amount of time, right? And if it's an acute treatment, we typically look at 90 or 6 months, right? 90 days or 6 months. But for secondary stroke prevention, we have to have patients in the trial for a very long time, which create challenges as it relates to budget and adherence and recruiting of patients, trial fatigue and all these things. So same is, I think, true for switch, but also took more than 9 years to recruit patients. I mean, you have to be very, as I mentioned before, persistent to be able to finish that, I think.
Absolutely. What about you, Ellis? What were your...
So I also wanted to mention that the TASTE trial, the tenecteplase trial, I was wondering what your take on this was. Do we need to ditch alteplase, or...
Yes.
The thing is that when you add TASTE in the meta-analysis, it shows superiority of TNK over TPA, and there are some similar stuff that's going to be presented in the scientific session, focus on meta-analysis, novel meta-analysis and new analysis, incorporating the new evidence of tenecteplase over TPA, so showing superiority. So I think it will accelerate the transition to TNK that is needed. So we have this shortage suffering over the last months.
Are you using it?
No, we don't have it. It's because of the shortage.
Yes.
So just for myocardial infarction, but then nobody uses it because we have PCA. So.
But you would use it if...
We would. Yeah. We would, for sure. Easy, more convenient, just single bolus. So it theoretically, it would improve the indoor-out times in community hospitals to accelerate the transfer to comprehensive stroke center. For sure is the future, is the reality in many other parts of the world. In the US, I think the transition is over. They just TNK, we're still TPA. But I think it was a long-awaited trial, TASTE. So it's not about advanced imaging. We know that now, so they suffer not only the COVID, but also other trials and also the shortage. But they finally did it. So not in the pre-specified sample size with 800 to 600, but still the results were not surprised. It's non-inferiority of TNK over TPA.
Of course,
regardless
when they put all that work into make the trial selected by imaging and selecting patients with a large penumbra, you could speculate why wasn't it more positive. And I noticed that Dr. Tumala had the question about the lacuna infarct. I think it was meant as to make the point that the TPA, whether it's alteplase or tenecteplase, benefits
works
all subtypes.
All subtypes.
No, I think there's been a lot of great trials, and we see all the hurdles that people have gone through, and especially in the past 5 years, I would say, there's been multiple hurdles in all of these trials. So we will now have a switch in our program here. So thank you, Carlos and Ellis. Claus, I would like to keep you here for a bit more. So. No, that's okay. we have a nice replacement for you. So thank you very much, and enjoy
the conference.
Thank you.
Thank you.
Thank you for inviting us.
Thank you.
So Maren and Natalia, you stay. So we have discussed the trials, the highlights of the morning, I would say. There's lots more highlights to come. But now we will switch a bit, and we will focus on the pre-hospital setting, I would say the main point of delivery of the patients to the hospital, and how do we find the stroke patients in the pre-hospital setting? How do we get patients from the pre-hospital, from their homes, to the right hospital at the right time, the right level of care at the right time? So we still have Claus, and you have done a lot of work on this in Aarhus in Denmark. We have Maren from Oslo, and you worked in the ambulance when you were studying, so you have experience from the whole chain, and Natalia as well from Barcelona, Catalonia, and you, of course, you've done a lot of work on the RaceCat trial, so very glad to have you here. So who should we start with, Robin?
We will start, I think, with the Catalonia effort, I think.
Yeah. So you've done a lot of work on trying to select patients, and you have had a lot of focus on the large vessel occlusions. So can you tell us a bit about your experiences with RaceCat and the trials you have done in your region?
Yeah, okay, thank you. Yeah, we start implementing a pre-hospital scale to identify LVO patients. So first we start developing the RACE scale. There are other scales, and then we try to demonstrate that using this pre-hospital triage tool, we could identify patients to do a mothership model, but then RaceCat was not positive in this way, and we have think a lot about that. And we can finally conclude that probably it's not the same for everyone. It depends on many things, and what works for Catalonia is not the same than everywhere. So it's nice to be here again to talk about that, because we can share a lot of different experiences in different geographic realities. So with focusing on the RaceCat, I will say that if a patient is a candidate for IVTPA, then I think that we have to prioritize IVTPA in the local hospital as soon as possible. And if the patient, if you can suspect a hemorrhagic stroke, and then we need tools to suspect this in the ambulance, then it's better to attend this patient in the local hospital. But there are some patients that probably need to be directed to an endovascular center, so we need to continue selecting this patient, and it's also very different in the urban area and the rural area. So we have a lot of work to do, and now in Catalonia, we are trying to implement thrombectomy in local centers. This is the first thing that we did after the RaceCat. So we are doing thrombectomy in primary centers, and then we are trying to improve the RACE scale to identify hemorrhagic patients and distinguish from LVO. Yeah.
So I will then go on to Maren. Maren, you have your PhD on the mobile stroke unit, and you completed the PARANASP trial. Tell us a bit about how do you view the pre-hospital selection, and what do you think we should focus on?
I believe that we need to have a broader focus on the patient population, because stroke patients are not only LVO patients, it's the total population of stroke has lower NIHSS scores. We can see from the Norwegian National Registry that 50% of the stroke population has an NIHSS of 0 to 2. And I believe that we need to rig a pre-hospital system that enables us to reach out to all of these patients, and that all of these patients should be selected for early acute treatment. And then we need to look at the chain of survival from the first contact, because there are several levels of selection before you end up in a hospital. And the first part of that chain is the dispatch centers. And up to now there has been some research on dispatch for stroke, but I think we really need to increase focus on the dispatch centers and to enable them to start the selection. And then we need to ensure that we, with new technology, actually enables the paramedics to have all the information that is collected in the dispatch for their use in a clinical assessment. And then we need competence in the paramedic staff to find strokes beyond the LVO symptoms. And NIHSS, we explored that in the PARANASP trial in Oslo, and it has some strengths, but it definitely some weaknesses as well. And I believe now we need to look into the other symptoms from the posterior circulation strokes. We need to look for sex differences, and we need to rely on new technology, because we can build in algorithms in these tools. We can specify them for different patient groups, and I believe that that is the future for selection of patients.
And so do you, because we're familiar with the trial of Fontenoy, of course, but do you know if there are, if that could be organized on a European level, because the organization of dispatch and ambulances and ERs and all these services is pretty diverse. And so how do you see that on the European level? Because there's, of course, this initiative also by ESOC focusing on stroke prevention all over Europe, the SAFE initiative. So do you think that something which is shown to be beneficial in Norway, for instance, can we implement that all over Europe, or how do you look at that?
I think first of all I want to thank ESOC for now encouraging us to do a new pre-hospital management guideline, and we will go through all the literature available, and hopefully we will be able to make some more statements next year. But I think the systems are different, but are not that different. All countries has a dispatch center, at least European countries, and the dispatch is communicating with an ambulance service in some way. And then we need to develop tools for communication between these parts of the chain. And I think we need to focus more on competence, because paramedics, they can be trained, and we need to train them. And we need to train them for 2024. Not with paper sheets. We need to train them with virtual reality, and we need to go out there and communicate with them in a much closer level than we do today. Yeah.
And Claus, what are your experiences from Aarhus?
Yeah, of course, we all would like to be able to distinguish the patient in the ambulance and say, this is hemorrhage, this is large vessel occlusion. But if anything, RaceCat and triage showed that maybe the most beneficial thing was just to get into a hospital, the nearest hospital, as fast as possible. And maybe we could get, more bang for the buck if we kind of invested in stroke awareness, making patients call the dispatch system, and as Maren says, train the EMS persons, and that they have a tool to investigate them. And if it's RaceCat, or if it's Race or another pre-hospital triage tool, it doesn't really matter. Our EMS persons, our ambulance personnel say that they like to have a tool to communicate with us. So sometimes they actually find it a bit intimidating calling the neurologist and try to explain these symptoms, but that and remember that the ambulance stroke is maybe 1% of all the calls. So and then it's not a normal day situation for them. So to have them to have a tool for them to talk with us, that is a great value. Then I know there are people doing research of where you can follow. You can have a camera in the ambulance. Actually, at my hometown, I don't know if maybe everyone knows this, but the dispatcher can actually make the caller send a link, and then they can press the link, and then they can, because everyone has a smartphone nowadays. So now they have eyes on the scene, and this can be done very easily. So I think maybe you're alluding to new tools and new systems. I think there's a lot of ground for us to improve patient care here. And then we can discuss, and I'd love to discuss, the intelligent direction of the patient. We really hoped that bypassing the primary stroke center and favorizing the comprehensive stroke center would benefit our patients. But we did the studies, and as evidence is now, it didn't. So now I think we should work on developing the primary stroke center so they can evaluate the patients quickly.
Yeah, probably our trials were not in favor of the direct transfer because the dripping ship is very well organized. And sometimes then you see, and I don't know, other experiences with a door-in, door-out time of more than 1 hour. In RaceCat it was only 70 minutes. So after RaceCat we have our experience is that times are getting worse after the trial. But yeah, of course, because when you are doing a trial, everyone is they know all the primary stroke centers. They know that they have to register all the times. So it's important to continue training all the system, and also to have a monitoring system. And it is the same for Europe. I mean, we were talking about if the recommendations can be the same. Yeah. Some of the recommendations are the same because everyone has to register all the times, and the pre-hospital time have also some different times that we have to monitoring and try to reduce. Yeah. So I think it's important to continue doing things out of the trials. Yeah.
I definitely agree. Yeah. We need pre-hospital quality indicators for stroke care, and we need them implemented.
Like door to needle or
and symptom onset, pre-hospital cycle times. Yeah, and I totally agree with the video possibility, and I think that's for future research definitely, and more than just asymmetrical facial. I think there is more into video than that. So.
Yeah, typically those quality indicators are somewhat neglected. Everyone's focusing on door in, door out, door to needle, door to groin. And then when you talk about what's the onset to a deep needle, well, that's outside of our hospital. Within the hospital, we cannot do so much about that. But of course, these kind of programs are essential to identify what can be gained by doing these kind of initiatives, and not just saying, well, that's outside of our hands, it's within the community, we cannot change it. Well, actually, probably we can by doing all these interventions that you're mentioning now.
So we're getting to the end, and I think I want to spend the last couple of minutes to discuss. You say focusing a bit more, you're moving intervention to the primary hospitals, and Maren, you are moving CT out of the hospital, not only within MSU, but placing CT strategic places where there is long transfer to the hospital. And that is, how do we provide imaging in the best way? And Claus, you have probably given this some thought as well.
Well, Claus is putting MR machines into
every street corner. No, I would be very interested in listening to what other people have seen with MSUs or the mobile stroke units. Of course, we all read the interesting article by the Houston group and how early treatment benefited. But of course, that was in a rural city where transportation times are short. But if the MSU is driving a very long time to get to the patient, dispatch is important. Do we send the MSU to the right person? I think as it is now, and with the geography in my region, the benefit of the MSU is probably not as big. I would guess, but of course it needs to be examined. But how do you use the MSU in Oslo?
The MSU project is not running at the moment, but I want to think out of the box, out of the MSU. I want to think how can we make the CT available for the stroke population. And I don't think we need to box it into a car. Some areas will be beneficial to have it in not a primary hospital, but like a out-of-office GP center, smaller facility. And we have a study going on in the mountain area of Norway, southern Norway, when this CT scanner is fully staffed and run by paramedics, and we train them to do the NIHSS to do the selection, and then we train them to do the actual, do the scan, and then all the interpretation and the communication around TPA or no TPA is done in collaboration with the on-call stroke physician in the local hospital with telestroke. And these kind of hubs of putting CTs out there, I think we need to look into that much in more detail, and not only think that pre-hospital CT has to be in a car. And with new technology, these CT scanners will be smaller. They will be cheaper. And they will, when we need to work together, ESO and the pre-hospital researchers, to make these available for the population.
So when I said we need scanners on every street corner, you actually took it serious.
Definitely. I think that we don't need a lot of infrastructure around these scanners. What you need is a simple non-contrast CT image, and you can do a lot of good care based on that. And we need then selection for patients whom to put into the scanner.
So it's like a mix between a mobile stroke unit and a drip and ship, no? It's like not a hospital, but a place where you can do a CT scan.
With telemedicine. So,
And we need to believe in training other healthcare professionals. I think neurologists don't need to be there to do all this work.
And maybe is it
we
useful
can train
also
them,
for
and
other...
we can do telestroke.
Maybe it can be used also for other, not only for stroke, for other emergencies.
I think for cost benefit, this analysis is very interesting, because between the strokes, then you can do ambulatory CT scanners for cancer patients, and you can reduce transportation time for critically ill patients, but they are living at home. And you can actually maybe increase quality of life as well, because nobody wants to stay in a bus for hours to get an ambulatory CT scan. So there are so many benefits out of this,
it's
and
a
you're
clever
actually
solution.
providing these CT scan that still is the core of acute stroke care. So
thank you. I think our time is up. Robin, do you want to summarize?
I think I'm very. It's very good to hear that you're working on this guideline. I think because pre-hospital care is really something that we have to invest in. We've been investing a lot in improving our acute treatments, and so we have to make sure that what we know is beneficial can be given to as many patients as possible. So looking very much forward to next year, where you hopefully will be able to present those guidelines. Thank you.
Great.
Thank you.
Thank you very much.
thank you.